Hello, my name is Dr. John Judas Hussey, and I'm currently a General Mills Foundation Clinician Investigator Fellow in the Department of Cardiovascular Medicine at Mayo Clinic in Rochester, Minnesota. On behalf of my co-authors, it is my privilege to discuss our article, A Novel Truncating Variant, an FLNC-Encoded Filament C may serve as a pro-arrhythmic genetic substrate in arrhythmogenic bileaflet mitral valve prolapse syndrome, to be published in the May 2019 edition of Mayo Clinic Proceedings. Mitral valve prolapse is a common valvular abnormality that affects an estimated 2 to 3% of the general population. Although largely considered a benign entity, the rate of sudden cardiac death in individuals with mitral valve prolapse is roughly twice that of the general population. Traditionally, the increased risk of sudden cardiac death observed in those with mitral valve prolapse is largely believed to be secondary to the sequelae of left ventricular dysfunction that arises in the setting of severe mitral valve regurgitation. However, life-threatening ventricular arrhythmias have been observed in mitral valve prolapse patients with only trivial mitral valve regurgitation. We believe this phenomenon may be explained, at least in part, by arrhythmogenic mitral valve prolapse syndrome. First described in 2013, this clinical entity is characterized clinically by bileaflet mitral valve prolapse in echocardiogram, inferior T-wave inversions on electrocardiogram, and right bundle branch block morphology, ventricular arrhythmias that likely arise secondary to prolapsing leaflet-induced fibrosis of the papillary muscles and infrabasal left ventricular wall. In some cases, this fibrosis can be detected by late gadolinium enhancement on cardiac MRI. Importantly, no genetic basis for arrhythmogenic bileaflet mitral valve prolapse syndrome has been identified thus far. In this molecular case report, we first describe the case of a 51-year-old male with long-standing bileaflet mitral valve prolapse and marked mitral annular disjunction, who presented with palpitations attributed ultimately to complex ventricular ectopy arising from the anterior and posterior medial papillary muscles of the left ventricle. Interesting review of this patient's family history revealed that his mother, brother, and maternal aunt also shared a similar cardiovascular phenotype. As a result, we utilize research-based whole exome sequencing and in silico gene prioritization algorithms to search for a shared genetic basis for the phenotype observed in this small pedigree. This approach led to the identification of an ultra-rare, novel truncating variant in FLNC-Encoded Filament C, a muscle-specific actin cross-linking protein involved in both mechanosensation and maintenance of myocyte structural integrity that co-segregated with disease. Interestingly, genetic variation in Filament C has been linked previously to the pathogenesis of dilated, hypertrophic, and restrictive cardiomyopathy. Filament C-mediated hypertrophic and restrictive cardiomyopathies are largely caused by missense variants that appear to be linked to progressive accumulation of abnormal cytoplasmic protein aggregates that likely result in abnormal cell signaling. In contrast, Filament C-mediated dilated cardiomyopathy, which is caused by truncating or nonsense variants that result in haploinsufficiency, appears to result from impaired myocyte attachment and mechanosensation. Furthermore, genetic variants in a closely related protein called Filament A have been linked to non-syndromic X-linked mitral valve dysplasia. Although we cannot rule out a novel effect of the Filament C variant identified in this study on the function of endothelial valvular interstitial cells, given the muscle-specific expression of Filament C, it appears unlikely that the Filament C variant identified in this study is directly responsible for the observed mitral valve prolapse phenotype. Therefore, we hypothesize that arrhythmogenic bileaflet mitral valve prolapse syndrome may actually follow a two-hit model whereby an underlying proarrhythmic genetic substrate, such as Filament C-induced haploinsufficiency that weakens myocyte coupling, is exacerbated by the force or trauma generated by prolapsing leaflets of genetically unrelated mitral valve prolapse. This hypothesis may help explain in part why most patients with mitral valve prolapse do not develop life-threatening ventricular arrhythmias, and two, why there's a relative lack of family history observed in most of our prior arrhythmogenic bileaflet mitral valve prolapse patients, as well as prior studies. In conclusion, this molecular case report provides the first evidence that some cases of arrhythmogenic bileaflet mitral valve prolapse may have an underlying genetic predisposition. Although the results cannot be widely generalized and should not be overstated, it does provide some evidence that there may be an underlying genetic predisposition to this condition. Future studies are needed to determine whether Filament C plays an unanticipated role in valvular morphogenesis and if some cases of arrhythmogenic bileaflet mitral valve prolapse actually represent a form of focal arrhythmogenic cardiomyopathy that arises secondary to the coexistence of genetically mediated weakening of cell-cell adhesion structures and unrelated mitral valve prolapse. I thank you again for listening to this discussion and for reading our article that appears in the Mayo Clinic Proceedings. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.